First of all, I'd like to thank Dr. Gaurav sir, Dr. Kudlu sir, Dr. Amrish Darak sir for giving me this opportunity. Okay, so I think all of us are doing the surface ablation, I guess. Mirror display. Okay, so I had a 24-year-old young patient who came back to me in 2016. He had a modest refractive error of 3.5 spherical with 0.5 SIL in the right eye, and in the left eye it was -3 sphere with 0.75 SIL with absolutely normal all other parameters. Only thing the catching point was he had a family history of keratoconus in the sibling. And patient wanted to join the army or the police. He wanted the absolutely 6x6 vision, and he was so much determined that he wanted to undergo a refractive procedure. So we waited for around 1 year for this patient, and after the proper counseling, what we thought, as he has a family history of keratoconus and his job requirements are there for the 6/6 vision, one should go ahead with the surface ablation. So we decided to go ahead with the two-step trans-PRK procedure, and with this performed on the Zeiss MEL 90. As we all know, in the Zeiss platform, we have to go first into the PTK mode. We have to ablate around 50 to 50 microns. Nowadays, we are doing the epithelial mapping and doing it, but at that time we didn't have it. So what we did, we removed around 52 microns of the epithelium. Then we just cool it down, because as we know, the temperature ranges up to around 38 degrees, which causes a lot of significant heat if you don't give enough time for the cooling. So we did this cooling with this wet Merosil sponge. Then we'd go into the PRK mode, treated the patient as per the refraction. And as we all know, we have to apply the mitomycin C to prevent the haze. So we use the mitomycin C, it was 0.02%, and we applied as a 1 diopter, 10-second exposure. Then we washed it with the 20 to 30 cc of the chilled BSS. We also used the ketorolac soaked BCL as well. So we did everything perfect what we could do with any of the surface ablation case. After 2 weeks, the patient was doing fairly well. These are my records. Patient was reading 6.6. Refraction, you would say, it's absolutely almost emmetropic. The patient was then lost for the follow-up, and patient came back to us after 11 months when he had a break from the army. And suddenly what we saw, there was a significant central reticular haze. Patient vision was 6/36, and the patient's refractive error came of around -6.25 sphere with 0.75 cylinder in the right eye, and almost -6 with -0.5 in the left eye. So at this stage, I was wondering what I could do next. I think the first thing which comes into our mind is to treat the patient medically with the potent steroid cyclosporine, as Pooja also mentioned, with the trehalose and the tacrolimus as well. So I started the patient on everything. And this is how this haze looked on the pentacam. You can clearly see over here. This is significant haze, and there was epithelial hyperplasia as well. I don't have the epithelial map here, but it was around 80 microns of the epithelium hyperplasia. Similar thing with the left eye, and this is how it looked on the topography. You can see this is a steepening, inferior steepening is there, which corresponds to that reticular haze in that area. Same thing was observed in the left eye. So again, I was slightly a bit skeptical, so we started the patient all this treatment, but unfortunately, patient developed the steroid-induced glaucoma only after the 1 month of usage. We started him on the prednisolone acetate because as the haze was quite significant. Then we gradually lowered the patient to the lotepredilol. We started for the 3 months. We gave the cyclosporine, we gave trehalose, and along with anti-glaucoma medication, but still there was absolutely no improvement. Haze remained the same. So the next thing which came to mind, what I could do next, whether I should go for the PTK, first clear out the epithelial hyperplasia, then treat the patient's refractive error. The patient was quite skeptical. He was absolutely anxious, nervous. We didn't know what to do. So I just gave the patient the glasses, and this is what I gave. And the patient was asked to follow up for every 3 months because I was slightly concerned whether the patient can develop the ectasia or no, seeing that inferior steepening and all. And we waited for almost, I would say, 5 years and tried to explain him to undergo for this PTK followed by the PRK, but he was absolutely not ready. So next question is what I can do for this patient. And this is what the readings came. Just recently I have operated this patient. 21st Jan readings are here. These are the March readings. So absolutely 2 similar readings I got. And then I decided to go ahead with the other procedure. And this is what the pentacam looked like. ACD 2.99. As you can see, this inferior steepening is there, which is absolutely stable. Absolutely nothing. All other parameters are normal. In the Bellin D is perfect. Just 30 seconds more. Similar thing was observed in the left eye. It remained absolutely stable like it was initially 6 years ago. Again, ACD of 2.93. So my question is, what would you do? So that is what I did. I wanted to play absolutely safe. So I went ahead with the ICL implantation. As you can see, it had a fairly good ACD, 2.92 from the endothelium. Another eye, again the same one. And this is how the patient is looking right now. Here you can see there is a slightly haze is there, central haze, reticular haze. But as far patient is doing quite good. So patient is reading 6/6, vault is pretty good, absolutely stable, everything is okay. So my question is, can any of the panelists have done differently from this? Because I wanted to play absolutely safe. The patient also wanted to play absolutely safe. And I think this was a win-win situation for all of us. Thank you.
What was the refractive error to begin with? I missed that first.
Begin was, sir, only 3.5 and 3. So I ended up having actually the double of that. So another reason I was quite skeptical of doing the re-PRK was that I might end up with the more significant haze. And
also, when you treated, I mean, when the patient came back, I noticed that patient was 636 and
Yes.
not improving or improving?
No, it was improving to 6/6 partial with the correction.
Because typically when you have haze of this kind, even the BCVA goes down as well.
Yes.
So that's one thing. And here actually epithelial maps would have been useful to see, but then, still nothing would account for 6 diopters of
Exactly,
myopia.
sir. So epithelial hyperplasia was there. It was 80-85 microns.
Okay.
It was not. I know. Yes. We did take the history. We also inquired whether he has a past taken disotetinone and all, but it was not there. So it was a quite unique case which I faced for the first time. It was almost patient reflection was -3 and I ended up almost double. So that's the reason I was quite skeptical for doing the PTK as well.
No, I wouldn't do that. Once
Yeah.
the patient has developed the corneal haze and the eye has responded in such a way, it tells us that something is wrong with the healing mechanism of the eye. I wouldn't
Exactly.
do the same procedure again. So I think what you did
Yes.
makes perfect sense to again do an ablation. Probably the
Yeah.
analyst can give the expert comments.
I would differ on that basically. Many a times, see, there are two parts. One is the doctor's job and second is the patient compliance. Many a times what happens in these patients, once they start seeing better, there is a problem with putting up the drops regularly, and particularly when you are doing PRK, you have to warn your patient n number of times to use the treatment for at least 3 months, tear substitute or whatever. And second thing, means by default, like I don't have all these equipments to map the things, but by default, whenever I am doing, in fact, few LASIK cases also, whenever I am doing, I use this cyclosporin by default in these patients. And another
So
thing
we
I do is,
give cyclosporin to all our PRK patients.
My first question is, why did you opt for PRK in these patients?
Patient had a family history of keratoconus in the sibling. That was my first thing. Although the pentacam was normal, absolutely was normal, I didn't want to take any chance. Second thing, he wanted to go in the army and the police one, which requires you to not to have those flap-based procedures. So that was the concern. Sorry?
Was he in army?
Yes, he was in army. So what I think, he was exposed to the more UV light, sunlight, and that caused this haze.
That actually justifies.
And he was lost on the follow-up because his training started. So that is the reason. That was the reason. So, but many of the times we get cases like this. So what could you do? This is the first time I observed this type of thing.
But the second thing is, like Ikra said, keep doing PTK in these patients where you are not sure, very sure of compliance, even PTK followed by PRK, or simply do PTK, the results are quite good in those.
Should we have used
Yeah.
mitomycin for longer time in this patient?
The second time when you do, we would use it for
For
2
second
minutes.
time, you have to use this
2
for
minutes.
at least 2 minutes. But I was not ready, even the patient was not ready, because I didn't want to treat the patient again with the -6 of, even PTK would have corrected, hyperplasia was there 80 microns, so I think max 2.5 diopter would have treated, still 4 diopter would have been left. So I don't know how the patient would have been after if I go. First time I did use, the normal protocol of using the mitomycin is 1 diopter, 10-second exposure. So I used it for around 40 seconds.
I think it's occupational.
Occupation is the culprit over here.
Add
So
one word
please
to
do that,
this
yes.
because I have put in 34 years in the army. You see, when a patient comes to you, you have to talk about occupation. Now, most of the people who are staying in Bombay or any of the places, they're sticking to one place. We are going all over India, from where it may be Siachen, that guy may be going to, down to the deserts. And these guys, mind you, when they don't go to big hospitals. And our government hospitals and army hospitals, in some tertiary hospitals only we are well equipped. But we are not as well equipped as you people are. We have only certain things. We don't have super specialists in all hospitals. In a small little multi-speciality hospital at 11,400 feet in Leh, we have one eye specialist, one ENT specialist, etc., etc. So if that guy is posted in Leh, he's not going to be able to get that treatment, he may lose his eyes. So my request as a person from the armed forces is, please, do consider that guy.
Yes,
He's
ma'am.
going to
We
get
did
only
also, in
25 to
fact, we did
30,000
advise.
rupees. And he's going to spend everything on his treatment. I feel very bad. I'm sorry about that. I feel very
we
bad.
did take the occupational history. That's the reason we opted for the PRK, because he wanted to go for the army and police. We knew that he is going to be exposed to this. We also advised him to wear the sunglasses and everything. But still, those people, sometimes patients don't listen.
So, in fact, I think
Exactly,
both of you are right
exactly.
in that. Because problem is that, they come to you seeking a solution. You try
Yeah.
to do your best for them. Problem is that the compliance may not be good and it's not possible for them to comply. Sometimes they may want to do it. They may not be able to put their steroid drops properly because they are on the, they're out on,
Yes.
they're out patrolling. They cannot wear glasses. In fact, I just tell this to many of them. I tell them, you can get non-colored glasses. They say, no, sorry, we can't even do that. Then I tell them,
Yeah.
you wear a cap. Protect yourself. They say, okay. So it may be beyond them to do all these things, and we have to keep that in mind. And you did your best.
Yes.
And but what ma'am has highlighted is also so important that we have to think of all those things that guy may go through. He may be desperate for a surgery, and yet it becomes our responsibility to understand whether he will be able to comply with what we are doing for him. So a low maintenance procedure would anytime be a better procedure than something, So I think you have to kind of judge all these things when you discuss with a patient. I think that's what it boils down to.
Then no matter what you tell them that you don't go for.
Yeah, they are
No,
not
they're
going to
desperate,
listen.
so I
No,
think we'll
ma'am.
go on.
No,
Yeah.
ma'am. They come to me, I'm now working in a corporate. I tell them, no. Ma'am,
Ma'am,
it's
they
a
just
firm no.
sometimes will go to another place which is happy to tell them that, come in, walk in, lie down and do it now, So, and they might get, ma'am, but then, that again is our responsibility because we are maybe losing that patient to a unscrupulous practice which may, so I think educating them and then maybe doing something for them is more useful than letting them go and get it done somewhere else and then still it's our responsibility we let them go into that situation.